Texas Lutheran University.
Good morning. I'm Dr. Mike Zuckery from the Psychology Department, and it is my pleasure to introduce our next speaker, Dr. Kim Gorgens. Dr. Gorgens is an associate professor, clinical neuropsychologist, and board-certified rehabilitation psychologist at the University of Denver. She has seen the acute impact of traumatic brain injuries as a paramedic, acute care team member, and in her own family. And she also studies and treats the longer-term impact of those injuries as a neuropsychologist, an educator, and researcher. Her work in this area is informing treatment in settings around the country, from outpatient clinics to the courts, and she's been featured on TED, CNN, and Fox, as well as Real Simple Wired and Men's Health magazines, among others. Indeed, it was her TED Talk that made me realize we needed to get Dr. Gorgens here to share her insights and expertise with the TLU community. Curiously, she does not find it the least bit weird to keep a mini refrigerator full of brains in her office. Please help me give a warm welcome to Dr. Kim Gorgens.
Hi, good morning, everybody. A huge thank you. Everybody has said the same thing, but what a program. I just want to give a super shout out and a round of applause to the whole Krost team, my colleague Dr. Helmer, everybody who's been so welcoming, and to you guys who are about to be a little bit peppier for me, right? So I'm going to start that round of applause for you guys, so thank you. This talk rounds out a nice flow of content from a long-term picture that Dr. Cantu started with for Chris Nowinski. Also, Dr. Helmer talking about this holistic picture. And let me just jump ahead to what Chris told us last night. You guys may have actually written this down. So Chris said, write this down, don't hit your head. My talk is, oh, damn it. What if you did hit your head, right? This is the talk about, okay, so you hit your head or someone you know hit their head. What are we going to do about it? So let's talk first about the count, the course of an injury, and levels of severity from the most broad perspective. Statistically speaking, according to the Centers for Disease Control, there are about 2.5 million brain injuries each year. In the room here, how many people have sustained a brain injury, mild or otherwise, that resulted in some transient moment of disorientation, headache, irritability, loss of memory? By a show of hands. Yeah, we're well above the 6% prevalence rate that's reported in the literature. How about family members or someone that you know who's sustained an injury to their brain? Yeah, it's nearly every hand here. So this talk is about what happens and what to do about it. And hopefully this takes some of the mystery away and maybe some of the fearfulness and hopefully addresses some part of the stigma that is one of the most significant problems for persons with these kinds of invisible injuries. So quick note about severity. So we have mild injuries, which comprise about 75 to 80% of the 2.5 million injuries every year. The other 20 to 25%, that's the moderate/severe category. So most people in this country sustain mild brain injuries. What's important to recognize about injury severity is that it is uncoupled in a lot of ways from the severity of the symptoms experienced. And you'll see that in some of the data that I present today. So persons who sustain a mild traumatic brain injury don't necessarily have mild symptomology following that injury. And persons who have moderate and severe injuries don't always necessarily have ongoing moderate and severe impairments, if that makes sense. So persons with mild injuries can actually have fairly devastating consequences and vice versa. And then course, what we're talking about, short-term, long-term, obviously you guys are here to hear about short-term, long-term recovery and management of symptoms. By definition, short-term management is in that first 1 to 3 month window. So we start to talk about post-concussive symptoms at about the 3-month mark. Some people talk about 1 month, but I think that's way too early. Most providers will start to think about the persistence of symptoms when they persist beyond 3 months. Persistent post-concussive symptoms come on board at about 12 months. So you can expect this window of acute recovery between 1 and 3 months, and then a slightly longer subacute period of recovery until 12 months. And then from there, we used to talk about, well, then you kind of plateau. And then we talked about a 24-month plateau. And what do we know now? What do you guys think? What do we know about the brain now? Like, is there a plateau? Like, your brain just kind of stops? It's done? No. Good thing for you guys today, learning something. Your brains are incredibly plastic, so it's an ongoing process, and we'll talk about how to use that to your benefit. So post-injury sequela or consequences. This is a schematic from our colleagues at the VA. And you guys, I should do a little sidebar apology. I'll talk way too fast, and I've never been accused of like going skimpy on content. I get this kind of hypomanic thing where I feel like I have to cover absolutely everything and give you your money's worth. My students right now would be rolling their eyes, and I appreciate that you guys are gracious and you're like nodding respectfully and being appropriate. So hopefully I'll get you on board and get you all kind of engaged and the content will resonate with you. That said, when I start going way too fast, somebody just needs to like put a shout out and say like, whoa, Kim, you're going way too fast. Okay, so this schematic from the VA makes symptoms look really complicated. Symptom presentation is idiosyncratic, and that is that no two brain injuries are the same. So people experience a set of common symptoms, but everybody's experience is unique. Dr. Cantu last night also had a puzzle, right, where he talked about visual problems and balance problems and cognitive problems and the way that all those puzzle pieces fit together. So this is another way of looking at the same thing. As a clinician, educator, researcher, this is way too complicated, right? Nobody needs to use that. So there are 3, and this is not just the Kim Gorgens 3. There's actually a tremendous amount of emerging research support for 3 kind of cardinal areas of symptoms with lots of downstream sequelae from there. But if you think about these 3 kinds of symptoms, and we'll talk about the way that treatment for any one of these 3 areas impacts the other areas, you start to see how the systems work together. And I promise you this will make you feel more empowered to manage your own concussion. For a lot of the sport folks in the audience, that may be especially relevant right now mid-season, or to manage the injuries of the people that you know. What's the first? What would you guess? It's headache. So headaches are the most universal post-brain injury symptom, and in a lot of ways, the most vexing. By definition, a post-traumatic headache, and you see that referred to as PTH or PTHA, is a headache that arises relatively independently within a week of an injury or within a week of someone regaining consciousness if they've had an extended period of, say, vegetative state, or within a week where they've discontinued medications like pain medications that may have been masking the experience of headache. What's really stunning about post-traumatic headache is that for headache, you start to see this discrepancy between the severity of the symptom and the severity of the injury. So for example, about 2/3 of people who have moderate to severe brain injuries report headache symptoms. Nearly all persons with mild traumatic brain injury, so 91%, report headache. So you start to see this interesting breakdown. What kinds of headaches are they experiencing? A number of different kinds. So some of them, the majority experienced daily headaches. Almost 40% had migraine headaches. Interestingly, 26% of those were new migraine headaches. And who are my migraineurs in the audience? Who are migraine sufferers? All right, so there's a couple of hands up. So we'll circle back to you guys because you have a unique brain and potentially a unique vulnerability. So 26% of those migraine headaches, which are kind of an idiosyncratic physiological syndrome in and of itself, 26% of those were new onset, and 9% had tension headaches. And sadly, and this is the vexing piece that I mentioned, nearly all, and by that I mean 95, up to 95% of people experience continuing headaches. So this is among headache sufferers, so not the whole population. So among headache sufferers, continue to experience headaches at 12 months after their injury. So let's talk about the why and the how. So why is it that headaches are such a common occurrence after injury? What's the pathophysiology, or what contributes to the exacerbation of those symptoms? Existing vulnerability. So for my migraineurs, or for people who experience regular headaches, your experience of headaches is exacerbated after brain injury. And how many of you guys had a headache, like let's say in the last 48 hours? Yeah, right? So everything you bring to the table when you injure your brain gets magnified after the injury. So everything about pre-existing vulnerabilities. Also for migraineurs, there's an emerging body of research that suggests that among people who have persistent post-concussive symptoms, that the rate of people who are migraineurs or who had a history of migraine headaches is overrepresented relative to the general population. So is there something about the physiology of the migraineur's brain that exaggerates headaches in an especially problematic way? Probably. Dr. Cantu mentioned last night cervicogenic headaches. These are headaches that arise from stress, functional, and structural disturbance to the musculature of the neck, also the face. There's also this, I'm going to have you guys put a mental pushpin. There's also an emerging body of research on neuroinflammation, and I'll just say the study of inflammation is everything right now in neuroscience. I mean, it's the whole study of aging right now. They're calling inflammaging, which is dumb, and you guys are like, really, I could have come up with something better. I did not come up with that, but somebody did. So inflammation is everything, and this will come back to me wearing a tinfoil hat shortly. But the data, again, like you'll always get real-time state of the science and too much of it from me. But the real-time data about post-traumatic headache is that likely there's some inflammatory mechanism that then, once initiated, is difficult to rein back in and get under control. There's also some indication that much like the way we think about post-traumatic stress disorder, for example, which we'll talk about later, but that there may be a chronic sensitization of the pain pathways that make them hair trigger responsive or over responsive to environmental stimuli. And then of course there's the psychology of headaches. And you can imagine my most common conversation with the patients and their families that I work with is around this conditioned pain avoidance syndrome, which is that when someone develops a headache, let's say during physical therapy, what's the last thing that they want to do the next day? Go to physical therapy. If they develop a headache while they're riding in the car, now they no longer want to ride in the car. And what's true of especially of headache pain is that people's worlds shrink so they're so small, right? Everything that they associate, everything they've done that they associate with having a headache during are things that they no longer feel like they want to engage in. So their worlds become really tiny, and then what happens? What's the psychology of someone who now they can't leave the house? Now they're in a dark room, they can't access treatment, care, social support. Right, they become depressed, it exacerbates the headache pain, so you get stuck in this really negative reciprocal loop. And then, of course, stress. What's the next symptom? You guys, it's a little bit show and tell. Like, this is a projective test for how I think about these variables. It's a head explosion. I'm kidding, it's not. What is it? What would be another huge factor when you look at all of the symptoms, all of the experiences after injury, that looks a little bit like this picture? It's the most closely related to suffering. Oh, hello, anxiety. Because, like, wait, that really was the worst image, anxiety. It's not bad, though, right? Now that you think about it. So, anxiety, and you could look at this a little bit broader brushstrokes and think of this as affective disturbance, in which case you're thinking more directly about depression. But I think about depression as kind of a close kin to anxiety. When you look at anxiety disorders, and you'll see why the shorthand of thinking about anxiety in particular makes a lot of sense when I talk about some of the science in just a minute. When you look at the emergence of anxiety symptoms, those rates are about 35 to 50%. So 1 in 2 people develop clinically significant anxiety symptoms after a brain injury. And those symptoms include things like PTSD, which we heard my colleague Dr. Helmer allude to earlier, generalized anxiety disorder, panic disorder, specific phobias, social anxiety, certainly. And then you see, interestingly, this little cluster of post-traumatic brain injury obsessive compulsive disorders, which is kind of its own little island there. Everyone has followed in the media the really shocking statistics that we're seeing, especially now out of the military, to look at post-brain injury suicide rates, which are shockingly and frighteningly high, and we're doing so much better to address the problems, but we need to do so much more. When you look at the convergence of anxiety symptoms and rates of self-harm, that's when you start to see a really clinically significant picture arise. So in this one study, this Kali study, which is one of my favorites, this is a longitudinal population-based sample that identified people who had a lifetime history of brain injury according to their medical records, and then followed them some as far as 45 years. So they had this long span of institutional records on this huge sample of people. And what they found was that people who had a lifetime history of traumatic brain injury, and by this I don't mean one uncomplicated concussive injury, I mean someone who had either extensive post-traumatic persistent symptoms or had clinically significant symptoms beyond the 12 months. So among those folks, they were 4 times more likely to die intentionally, and we tend to define suicide as kind of traumatic, self-inflicted shooting, for example, jumpers, we have overdoses. They looked more broadly at intentional death, so this might be medication mismanagement, for example, someone with a diabetic condition who didn't manage their medications appropriately. So people with a lifetime history of traumatic brain injury were 4 times more likely to die intentionally in this longitudinal sample. We also know that anxiety is what is the experience of human suffering. That is the existential angst and the pain, the experience that people have that is so aversive after brain injury. We know that when we operationalize and study anxiety, that you see it show up as most closely aligned with levels of psychological, occupational functioning. You also see rates of benzodiazepine, things like Valium, for example. The abuse of those drugs skyrocket, which poses incredibly huge problems for start to finish in terms of withdrawal from those drugs and abuse of those drugs. And those are the folks who show up in the healthcare ranks more often. So they have more emergency room use, they have more acute care use, so their symptoms are not being managed effectively. And then there's an emerging body of research over the last couple years that says that something about anxiety may actually be one of the underlying mechanisms behind exaggerated cognitive impairments. So that some part of the The construct and the experience of anxiety is related to cognitive impairments in all the ways that we think about them post-injury. So memory impairments, executive function impairments, et cetera. So why and how for anxiety? And you'll see my little friend there, and we'll circle back up with him in just a minute. But first I want to talk about the physiology of anxiety after brain injury. There is a lot of new and interesting data pointing to the structural and functional differences in the brains of people who sustained a brain injury in ways that relate directly to the processing of environmental stimuli and the experience of anxiety. So here you have from some fMRI data indication that not in these huge fiber tracts, which would be the superhighways, but these little interstitial fibers, which would be like the surface roads or the street roads, if you were looking at Google Maps, for example. So if you impair communication along those arteries in the brain, then you lose, and not arteries like cardiovascular, but arteries like roads. If you impair travel along those roads, then you lose some part of functional connectivity between different regions of the brain. There's also really interesting research looking at metabolic dysfunction. So everything we know, especially about a mild brain injury, is, and you heard this over and over again last night and this morning, a mild injury is not a structural injury. So using our contemporary hospital-based neuroimaging technologies, we can't even see it. As a matter of fact, the definition of a mild injury is that we can't see it. And if we can see it, then by definition, it's not a mild injury, it's moderate or severe, right? So if you have a bleed, or if I can see a midline shift from swelling, whatever, if I can see it, it's no longer a mild injury. So to think about mild brain injuries as a metabolic injury introduces a way of making sense of all of the downstream symptomology. One of the metabolic consequences of especially mild injuries is hormonal dysfunction or endocrine dysfunction. And one of the hormones that has led the pack in terms of being identified as deficient in persons who sustained a brain injury, and in rodent models been identified to account for some part of their behavioral presentation, is growth hormone, interestingly, which we all know is associated with, hello, growing, but you don't think of it in terms of anxiety. But actually these rodent models now are pointing to, hey, growth hormone actually plays a really important role in affective management. And then I want to talk about psychology. And here's where my little friend, a little B6 mouse, comes in, or black 6, sometimes you hear them called. So this relates a lot to stigma. And let me tell you a story about how people who are doing rodent research, what they'll tell you anecdotally, and then I'll tell you what we're looking to study now at the University of Denver. So what people who are doing, especially concussion research with mice, will tell you, and most of them are using these little B6 mice because they're hand tame and they're kind of docile enough that you could pick them up and strap them down onto this awful thing. And PETA folks should close your ears for just a minute and strap them down and concuss them with a little tiny hammer, and then you study them and rate in like water mazes, or you dissect their brains right there and take a look at what happened. Okay, now you're gonna open your ears again. Okay. So no more gross stuff, I swear. So one of the things that you hear from all of the researchers is there's this curious phenomena after injury, so after you take them out of the apparatus, that their behavior changes. So this is, they're not in cages, right? They're in like little clear buckets. So while they're in their cages, their behavior is very different, and they don't return to baseline in interesting ways. And what we know about our concussion analogs in rodent research is that we're probably not actually recreating truly mild injuries. They're probably more moderate to severe. But what's really interesting about these mice is that they become fearful. So the mice that you would normally be able to like reach your hand in, and they're dumb enough to like walk up to your hand and you scoop them up and you set them down, they're no longer, now you have to chase them around, and it's just kind of a thing that everybody who's doing rodent research is like, you know, hey, there's this weird thing and what we notice, but nobody has really studied that meaningfully, the behavioral presentation. And so at the University of Denver now, at the Eleanor Roosevelt Institute for the Study of Neurodegenerative Disease, we're tracking this behavioral presentation, and we'll run through kind of peer analogs. So how do they behave with their peers? And it's this really interesting model that some part of this behavioral presentation of anxiety, right? So suddenly being fearful may be physiological. The reason that I've lumped that here with psychology is that there's so much stigma around the experience of anxiety and depressive symptoms for persons who've had a brain injury. There are all kinds of reasons around the invisibility of that injury, and we'll talk a little bit about relationship changes in just one second. But if you can, and this would be for yourselves, for other people, and the conversations that you have, if we can reframe that, people take anxiety symptoms, phobic reactions, they take those to mean a moral failing of themselves, some kind of character deficit, right? It drives them away from the care, away from the resources they need to manage those symptoms, right? They're embarrassed, they're shameful. If we can reconceptualize those symptoms as a physiological product of the injury, people may be less averse to seeking and receiving the care they need. So I make that huge plug. Subjective versus objective deficits. There's a lot of this research, especially in the acquired brain injury world, also in like chemobrain, a lot in cancer research, and some in post-concussive samples. So one of the interesting things is that we talk a lot about the cognitive presentation of injuries. So these are people that we find in our offices for neuropsych evaluation because they're presenting with cognitive deficits. And the really interesting thing is that the measurement of those deficits, we see them, right? Like, oh, I see where the impairment is. I can see that very clearly on my tests. Is that there is a discrepancy oftentimes between the magnitude of impairment that the person perceives themselves to have and the objective assessment of that impairment. So people oftentimes perceive themselves to be more impaired, and that gets exaggerated by what is called in the research good old days bias, which is our tendency to believe that we used to be way smarter than we actually are. So, although you guys probably were really that smart, but so it may just apply to me. But this tendency for us to think, you know, before I got dinged, I could memorize a phone book. Right? When realistically, and research bears this out, that when you have pristine pre-injury data and you compare pre-injury to post-injury data, that the changes are much less significant than the person perceives. So again, kind of this self-perception, anxiety piece comes in there. And then, of course, relationship changes. So these injuries are invisible. And if you had a broken leg and a cast, everybody that you know and your friends and family, the teachers in the classroom, everybody does what? They go out of their way for you, right? They like hold the door and they're like, oh, hey, should we prop your leg up on a chair? And people go well out of their way to accommodate your injury and to accommodate your rehabilitation. With an invisible injury, it's really easy for them to be like, what the hell? And angry outbursts or irritability or sad outbursts or memory deficits, those kinds of things can lead to all kinds of interpersonal friction that then reduces the amount of social support available to the person with the injury. And then just really quickly, to say something about the brain as our veneer. So persons lose some part of their veneer after brain injury. So what's very common is that if someone had we talk a lot about frontal lobe function, to manage an underlying anxiety disorder or depressive disorder, or they might have had some other persistent mental illness, when you compromise the function of the brain, it's like the veneer wears thin, and so you start to see, in a more exaggerated way, the occurrence of the symptoms associated with that disorder. What's the third bucket? Oh, hello, sleep. Yes. So here's my gal pal in her EEG hat, right? This is her net cap doing an EEG, and nobody has that much fun doing an EEG. But sleep is the common denominator for everything, period. Full stop. I should be like Chris and say, like, okay, write this down. Sleep is the common denominator for everything. If that's the only thing that you remember as like, well, I think Dr. Gorgens said something about what we should do after brain injury, if the only thing that occurs to you that I said today is sleep, I like won. Like, you just won the conference. So sleep is almost always disrupted after an injury. Statistically speaking, in almost 80% of patients, it's everything from difficulty falling asleep, staying asleep. You see also the emergence of disorders specifically related to the injury. So you have positional sleep apnea and traumatic brain injury related hypersomnia, which is kind of a failure to manage arousal during the day. And then just to make a quick, like, world's fastest detour on sleep so that you understand what we lose. So for sleep, the most common interruption is the loss of slow wave sleep and the compression of the other stages of sleep. So in a nutshell, here's the sleep architecture that is typical for most people, although how many of you guys had 8 hours of sleep last night? Okay, there's like 6 of you maybe in here. So kudos, well done, you're doing it right, you just won. For the rest of us, it probably didn't look like this, but the 2 areas of sleep where it really is at for cognition and mood, slow wave sleep, stage 4 sleep, and REM sleep, right? Both play really vital functions. And what you see characteristic after brain injury is a loss of both. So both areas, the slow wave sleep is the restorative sleep where you have some, the body addresses inflammation, for example, in slow wave sleep, and then REM sleep is especially important for memory consolidation. You lose both of those. There's also a lot of research looking at sleep now as one of the mediating variables, together with things like premorbid history of trauma, that account for the relationship between traumatic brain injury and development of PTSD. So sleep is huge. So bold, italics, all caps. Why and how? Everything about sleep is super complicated, and it's a sticky variable because it's related to everything else. So people who are not good sleepers, so people who are shift workers, for example, have a much higher rate of sleep disturbance after brain injury because their sleep was all kinds of jacked up before. People who, in the audience who may have been super night owls, right? You guys may be a little like me in that way. Right? If your sleep-wake disturbance is off after an injury, let's say you have a period of time where you stay in the hospital, right, and the lights are on and people are in and out, those kinds of things impair sleep in really meaningful ways. And just to put a little plug in for sleep hygiene for college students, which you guys are like, what is that? That's impossible. But in research settings, we operationalize sleep deficit as 1 hour of sleep loss a night for like 3 consecutive nights, which is college, right? So when we're measuring deficits, it's like, well, this is what sleep disturbance look like. We're actually just measuring the experience of college students. So, and then I have my friend here, the Doberman. One of the models of post-brain injury sleep disorder is that it may look a little bit like narcolepsy. There's a neuropeptide called hypocretin that promotes wakefulness, and when you produce less or you have fewer hypocretin receptors, you have a difficult time maintaining wakefulness. So there's some indication that that may be also the case for traumatic brain injury. So what do we do about all that? Here's the thing that makes the 3 model particularly brilliant in its clinical application. If you fix any one of those, and by fix I mean address and attempt to ameliorate symptoms in any one of these 3 areas, what happens? Symptoms improve or abate in the other areas. So you get a ton of mileage out of an intervention for sleep, for example, right? You see an improvement in anxiety and an improvement in the experience of pain. Similarly, if you address pain, you see a reduction in anxiety and better sleep. So it's a really efficient way to use your time and resources in one of these 3 areas. Otherwise, there is the Also popular and as effective model of playing whack-a-mole, which I have here, which is to do kind of singular targeted interventions for specific symptoms. For example, cognitive rehab for a memory loss, right? You could like drill down, nail that, and that's great too. You don't see the diffusion of return with those whack-a-mole kinds of approaches. So headache, here's my tinfoil hat. This is me in the tinfoil hat, just as an FYI. So I mentioned that headaches are particularly vexing. The reason they are is that there are no established evidence-based guidelines for the treatment of post-traumatic headache, which means that every neurologist, physiatrist, primary care doc is treating that person's symptom as an idiosyncratic presentation of injury. And when you think of, like, this is the most common symptom after injury, it makes for a tremendous amount of variability in the treatment approaches. What you'll get from me in all of these areas are only the most effective. So medication, obviously, this is everything from over-the-counter pain medication, also things like antidepressant medication, anti-epileptic medication, which work to suppress post-traumatic headaches in a lot of people for reasons that we don't even fully understand. Physical therapy, where's my athletic training students in the house? Nice, right? Like, hello, this is where you guys come in. So this is strengthening and conditioning, a lot of the interventions around neck work after brain injury, right? This is going to fall into your office a lot of times. Cognitive behavioral therapy, hello, if I wear my psychologist hat for just a minute, cognitive behavioral therapy interventions are really effective also for headache. And then one of the most promising interventions that people hate when doctors say is aerobic exercise. Asterisk, when they do research on aerobic exercise, and this would also be like what people hear when you say, like, you should try some exercise, which everybody hates to hear, let's be honest, unless you're maybe the person who's like, yeah, I should do more of that. Kudos for being that person. But what people hear is, like, I guess I got to train for a marathon, or like now I have to do CrossFit 2 times a day. I don't understand what that means. In the research samples, they're operationalizing cardiovascular activity as 60 seconds of elevated heart rate. So it's like a little teeny burst. It's not even like the 45 minutes, and I have to get like Orange Theory Fitness, if anybody do that. Like, I have to get my heart rate into this target zone for so many minutes, right? The research sets the bar incredibly low. So that should make you all feel better. Like, whoever had to run here today, well done, right? You are like, and you slept well. If you slept well and you ran here this morning, you're killing it, right? That's well done. My tinfoil hat is about Advil. Again, this inflammatory model of every system in the body, the disruption of those symptoms is huge. This is not an endorsement for Advil, but I mean it to say that there is something about even the non-steroidal anti-inflammatory drugs like Advil that actually have remarkable effects relative to things like narcotic pain medications. So for aerobic exercise, just so that you have this, and I'll make this available, these are the Zurich return to play guidelines that Robert Cantu mentioned and alluded to last night. These have been adapted in Colorado and sourced out to the country as also return to learn guidelines, and then you also have these as loosely return to work guidelines. Essentially, it is a stepwise or sequential model from rest through full exertion. And full exertion could be physical activity if you're talking about a sport, or it could be full participation in class and homework if you're talking about an academic setting or a work setting, similarly. So anxiety then. One of the most effective treatments for the management of anxiety is to support the people who support that person, which makes tremendous intuitive sense, but for a long time in the research, it didn't occur to us to do that kind of investigation. Like, hey, you know what actually really matters is if you support someone's roommate with the information they need, or a spouse, or their family, or coworkers, or the person writing their performance evaluation at work. If you support those people, and by support I mean it's education, it's reassurance, it's reframing, all the while reassurance and reframing for the patient themselves. But if you support those people that the person with the brain injury leans on or makes use of support from, that person's anxiety abates. And there's really interesting research, especially in pediatric literature, that these simple family interventions actually have remarkable behavioral impact in the presentation of kids. Psychobiotics, where's our new brain? Anybody know that? Where's the brain that we're talking about now in neuroscience? Oh my, you guys are like, what? It's not in your head? It's not in your head. So the new brain that we're talking about is the enteric brain, which is the brain that's in your gut. And you guys are like, I maybe didn't have anatomy this quarter, but I'm pretty sure that wasn't where the brain was on the model. Yeah, it totally is. So we have more serotonergic neurons that line our gut, for example, than we do have in our central nervous system combined. So there's this really interesting paradigm shift afoot looking at the role of our GI tract in the emergence and maintenance of symptoms, especially after brain injuries. So really promising work on psychobiotics. So this is like the probiotics that you might take in capsule form or in yogurt, right, that maintain gastrointestinal health. Guess what? You may also be doing a tremendous benefit for your brain, especially at a time when your brain is compromised. And then cognitive behavioral therapy. So relaxation, I have a script just on that last. Here are some examples of the kinds of things that people need to hear that are so easy. You're not lying to anybody. These are all founded in truth, but these are the ways that people get their anxieties, their fears, their expectancies get away from them, and this re-grounds them in the moment, right? This gets better. This is slow, but it gets better. This symptom means you're not at 100%. This symptom flags us to manage that symptom better. It doesn't flag you as impaired or a long-term deficit, right? So if we use symptoms as temperature gauges, for example, you use them more meaningfully. Sleep. I never go straight to medication, but I just want to make a note. Cognitive behavioral therapy for insomnia is far and away the most effective treatment, but people always want a pill, right? That's why sleep aids are billions and billions of dollars a year in pharmaceutical trade. Everything about pharmaceuticals is bad news for sleep after long-term use, for sleep after brain injury, for all kinds of reasons. There's this Rosarum, which is a new drug that I have no commercial stake in whatsoever, but it works on melatonin pathways, and there's actually really interesting kind of real-time research now on short and long-term use of Rosarum, and that it may not create kind of rebound insomnia like a lot of the other pharmaceutical drugs do, and certainly no dependence. So I put that on there just as like, okay, if you have to ask for the tablet and somebody is insistent, then you go there. Otherwise, it's always CBT for insomnia. And that is, how do you talk to someone about sleep hygiene? Again, it's like hearing from the doctor that exercise would be helpful, where you're like, what did I just pay you for? You're supposed to give me a prescription for something. So people think that same way for CBT, for insomnia and sleep hygiene. Like, really, I came all the way to the doctor for you to tell me not to use my device in bed at night? Device, I mean, not anything personal. Because like, wait, I thought that was Dr. Helmer's talk on sex. No, I'm talking about handheld screens, right? Blue light devices, so iPad, iPhone. So here are examples of sleep hygiene. It's everything you're not doing except for the people who slept 8 to 9 hours last night, right? It's all the things that we're terrible at doing, all the ways that we compromise our sleep in favor of more work or making mental lists. Everything that we're doing is wrong. Here's what you need to do differently. The caveat to this is for naps. So napping is very different after traumatic brain injury than it is for the rest of us. So after brain injury, napping is less like, hey, I feel kind of tired, I think I might go lay down. For persons after brain injury, napping is like a hard stop. It's like they have a finite amount of energy during the day, and if they exhaust it by, let's say it's 11 in the morning or it's 4 in the afternoon, they hit a hard stop. Like there's no like, well, let me take a walk and regroup. So napping and being strategic about managing a finite amount of energy during the day becomes really important to sleep hygiene. And sleep hygiene, napping, in a non-compromised population looks like not napping for more than 20 minutes at a time. For someone with a brain injury, napping will look very different. Does someone need to pace themselves with 2 short naps, 1 very long nap? What does that look like, and how do we make that happen? So finally, I want to close with the wild card. So these are the things that either create more problems for the person after brain injury, or might create all kinds of related iatrogenic effects or treatment-related adverse outcomes. So the first is environmental hazards. So everything we do to push ourselves to get better after brain injury can actually be impeding our brain's ability to repair itself and for our every system's ability to adapt and accommodate to this new metabolic functioning. Fluorescent lights, for example. Overstimulating environment. So a lot of you guys in dorms who have a noisy next door neighbor or someone who's like a roommate who's really noisy or watches TV at night, that kind of stuff that in a non-compromised world where our brain is functioning at relatively close to 100% or whatever make-believe number that we might all get to in the course of a day, all of that stuff that we don't even think about can impair our recovery. Iatrogenic effects. So research shows that when you tell someone that they may experience some symptoms, guess what happens? They experience those symptoms, right? Well, you may find that you get a headache and you feel anxious and you may feel like harming yourself, and then we're surprised when they show up in our office 3 months later and they're like, oh my God, all those things were true, right? This is like why pharmaceutical companies are like, we don't like this whole informed consent that they do on the drug commercials. Like, you know, it could cause all these negative things because then people are thinking about, right, it's nocebo effect. They're like, oh my God, I have that shortness of breath. No, I have that for real now. So it's so important. And then when you do research that like assigns people to 2 groups, one group says like, you're gonna find that your symptoms remit in within 3 months. And you know, if they don't, here's some part of what some people experience and we can manage all these things. And the other group that, here are the common symptoms, you may find you experience some of these, that their outcomes short-term are very different. So messaging is really important. My favorite is the Ericksonian suggestion in your favor. So you might find that your symptoms remit in the first week, right? It doesn't mean that like you're playing some magic parlor trick and their symptoms are always gonna get better, but why not leverage that in your favor? The rule of thumb is that you bring in specialty assessment at 10 days. So inside of that is really a waste of your time and money. Rest, Dr. Cantu alluded to this. The pendulum has swung both ways. We used to say, like, you should get right back up on the horse and back on the field. And then more recently, in the last couple of years, we had these like absolute rest, absolute cognitive and physical rest for 7 to 14 days. And now, right, the pendulum has swung back and found that, you know what, absolute rest for 7 to 14 days is as bad as no rest. So now the current state of the science literature says that rest is good, but for no more than 2 to 3 days, right? Then you should start progressing along that exposure to activity, so cognitive or physical. Unsupported intervention, this is the scourge of the brain injury world. There are billions and billions of dollars on the table from consumer spending. People are vulnerable to exploitation from people who want to sell them interventions for whatever price tag. People would leverage everything if they thought that some intervention was going to be effective for their loved one. So you have to do your homework. I have a picture here of a hyperbaric chamber, which is not to say that I think hyperbaric chambers are dangerous post-traumatic brain injury. But what I mean that to say is that the research on the use of hyperbaric therapy after traumatic brain injury is immature. It is not well supported yet, and it may turn out to be the most efficacious intervention ever, right? Our most valuable tool that we have in our arsenal. Right now, the science doesn't bear that out. The same with these Erlen lenses, which are these colored lenses, which like without fail, every one of my students who sustains a concussion, they get in touch with me, will show up in these lenses because their doctors will be like, well, you should wear these colored glasses to promote recovery. There's more robust research looking at stroke recovery with these Erlen lenses. There's very little in traumatic brain injury. So just be thoughtful. Why not spend your time and your money on something that at least there's some reason to believe will actually be effective? Substance abuse, the kiss of death, especially alcohol. So if alcohol is on board at the time of an injury, the outcomes are poorer. The risk for developing a substance use disorder after brain injury is much higher, so recognizing that there's this new vulnerability to developing a new novel substance use disorder. And alcohol is problematic in terms of neurogenesis and neural recovery in all kinds of really pragmatic ways. It also reduces seizure threshold. You may have an increased risk for seizure after injury. So substance abuse is kind of a major game changer. And then finally, what about that next injury? Appreciating that your risk after an injury, your risk of injuring your head again is, for reasons we don't even fully understand, much higher. And then after a second injury, it's astronomically higher, third, etc. So it's like, are they just clumsier? Maybe. Is it that your metabolic vulnerability to injury is greater? Hells yes. So the rule of thumb is that your physiological vulnerability outpaces your experience of symptoms tenfold. So at a time when you feel like you're symptom-free, you should assume after an injury that you still need to baby and protect your brain for a tenfold long period of time. So if you have 1 week of symptoms, right, you should take another 10 weeks to guarantee before you put yourself in a position where you're exposed to that much risk. And I don't mean necessarily return to play. I do mean being really thoughtful about style of play, right? Understanding that, hey, some part of my brain's physiology right now is compromised, and waiting that out can be really important. And there's really interesting data looking at magnetic resonance spectroscopy that finds that the signature of injuries don't clear for that tenfold period of time. So with that, I thank you, Bulldogs. I hope you guys all take care of your brain. And if I can ever be helpful, you guys know how to find me. Many thanks. Oh, I guess we have a couple minutes for questions. I thought I used up all my time. And I promise I won't blow your hair off.
I'll pose one question to you. We're in the practice of, especially with athletes who have concussion, that we do a student alert to the dean of student bypass.
Yep.
That goes out to the professors who know that, all right, Joe had a
Right.
concussion. What should they do with that as a practical tip? How can they, because a lot of professors go, hey, I know so-and-so had this injury, and being a professor yourself, how can you manage still being in charge of the classroom,
Right.
juggling those demands?
It's such a great question, and there's so much interesting momentum about how to do that better. So the reason to identify yourself or to flag a student as having an injury is so that the person standing at the front of the room knows to be watchful for the kinds of symptoms that are likely to be problematic for that student, and it alerts me to think about those symptoms differently. So for example, if someone looks inattentive, and I know to look at them as someone who has just recently experienced a concussion, for example, then I think about their inattention differently, right? And it occurs to me to, hey, I need to circle back to this person. Maybe this is someone who needs to meet with the TA outside of class. Maybe there's something about the format of the lecture and the PowerPoint and the buzzing of the projector and the noise of people walking back and forth in the hallway that's too much, right? It flags me to think about them and their experience differently. The interesting thing is that we find that when we flag students in that way, that this speaks to the recall of the people who are teaching the classes, hello, I mean me, is so poor. So we've actually experimented with things like, should people with concussions have like a wristband? Or should there be something that would flag them to their peers? And I don't mean this in a scarlet letter punitive way, but a way that says like, hey, you have to cut me some slack here, and I'm gonna need a little extra support, TLC, whatever. So any intervention for the teachers in terms of capacity building and education is only as effective as it is recallable for the teacher themselves. Same for coaches, right? That the kid who doesn't look injured is the kid that isn't pinging on the athletic trainer's radar, for example, as warranting additional support as they get on the field. Yeah, it's a great question.
For the study on the mice that you were talking about, could it necessarily be that they run in fear because of...
Thank you. You are thinking like such a brilliant psychologist. Hell yes. So, and the reason, so that was always how we thought about it, right? Like, oh, we're kind of ruining them, and they develop this post-traumatic response to being strapped onto a little piece of cardboard and then whacked with a hammer, either with air or a water hammer. So, yes, and PETA, close your ears again. So the way that they tested that, and this has happened at DU and some other places, is to do other tissue injuring. So if you fracture a forepaw, for example, they don't develop the same phobic response when they're placed back in their, like long-term phobic response where they cower. They don't. So for other kinds of deliberately inflicted injuries, they don't have the same response.
Okay.
But thank you, because that was not complete without that. So
Okay, thank you.
kudos to you. You probably slept 8 hours last night. All right, thank you guys.
Students at TLU engage in high-impact educational experiences that include civic engagement, aesthetic expression, critical thinking, and a focus on intercultural knowledge in a community that welcomes the interplay of faith and reason.